we're excited to talk to you this evening. Or please may I also ask if you could possibly mute yourselves and stay on mute in order to hear the speakers clearly as we carry on. So yes, as Margaret said, my name's Helen Ramsey. I'm the lead governor at South Central Ambulance Service. I'm a public governor for Oxfordshire, and I'm very much looking forward to chairing this session. The talks will explore the connection between falls and frailty in later life, with a focus on practical steps for prevention, what happens when a fall occurs, and what to expect during hospital care and recovery. We'll look at common risk factors for falls, how frailty can affect recovery, and ways to stay safer and more independent for longer. And tonight we have three excellent speakers here to help talk through these topics. The first is Mark Ainsworth-Smith, Maz, Consultant Pre-Hospital Care Practitioner, South Central Ambulance Service, NHS Foundation Trust. Mark Ainsworth-Smith, who likes to be known as Maz, has worked in South Central Ambulance Service as the Consultant Practitioner since 2007. Before then, he had an accident and emergency background and has worked in a frontline NHS role since 1987. Maz is an active clinician and attends many life-threatening emergencies every year. He was appointed an MBE by Her late Majesty the Queen in 2018 for services to emergency care. The second of the speakers is Harry Punn, Occupational Therapist, Proportionate Care Medicine for Older People team at University Hospital Southampton. Harry Punn is an advanced occupational therapist who has worked in multiple specialities, including general intensive care, stroke and medicine for older people. He is now in a joint role of the Proportionate Care team and team lead for medicine for older people, promoting proportionate care within the geriatrics caseload at Southampton General Hospital. And with him is Hannah Foxley, Advanced Specialist Occupational Therapist from the Proportionate Care team. She's an experienced occupational therapist with over a decade of practice in NHS acute hospital settings. She has a strong background in managing frailty and played a key role in establishing the emergency department therapy service at Southampton General Hospital. Currently, she serves as the Proportionate Care Clinical Lead at University Hospital Southampton and the Hampshire and Isle of Wight Integrated Care Board. We have a packed event this evening and the speakers will do their very best to keep to time so that there will be an opportunity for you to ask these leading healthcare professionals the questions you need to know before the event finishes. Please may I ask you to pop your questions in the chat function. That would be brilliant. My governor colleague, Tim Ellison, an experienced community first responder, will be chairing the questions and answers at the end of the talks. And so, without further ado, I would like to hand over to Maz from SCAS. Thank you.
So thank you very much. I just want to check that you can see my slides, but I've got a slight issue.
We can see your slides, Maz, but they're not in presenter mode.
Yeah, and I don't know why that is. Let's just try that again. We might have to call. Oh. Can you see that now?
Yes.
Fantastic. Great stuff. Thank you very much. So just to introduce myself, my name's Mark Ainsworth-Smith. I'm the consultant practitioner, and yeah, I've worked in SCAS since 2007. And the purpose of tonight is I'm going to tell you a little bit about an ambulance service perspective. Has that advanced the slide okay? Fantastic. So I guess we should be clear, first of all, of what a fall is. And the best definition I've ever found is this. It came from the Kellogg Working Group from 1987. But it says that a fall is an unintentional event that results in the person coming to rest on the ground or another lower level. So we've got a really good definition there. And I'm going to tell you a little bit about what we do in the ambulance service. There is some fantastic news in that people are generally living healthier, happier, hopefully, and longer lives. And I love this picture on the left side of this elderly gentleman showing his undying love for his wife. And I think that's just a fantastic picture. But what we've got in the middle of the slide here is a picture showing us, a graph showing us how long we live. And what you'll see is that in 1840, the average male only lived to the age of 40. The average female lived to the age of 43. And then, of course, there's been advancements in mainly medical care, but things like antibiotics, insulin, everything that we add together. And what that actually results in is a massive improvement in life expectancy. Now, I know this data looks slightly old. I can't find anything more up to date on the internet. But what you'll see is the average male lives up to the age of about 79, and the average female lives to about 84 or thereabouts. So there's some really good news pictures here. But the bad news is that as we get older, unfortunately, that makes us more likely to fall. And what we do know is that 30% of people aged over 65 will have a fall at least once a year. We know that as you get older, that risk increases, so that for those aged 80 or over, it's 50%. So half of patients over the age of 80 are going to fall. And we know that care home residents are 3 times more likely to fall than elderly, frail people living in their own homes. And that also applies to hospitals. If you're in an environment where you're not familiar with it, then that makes you more likely to have a fall. And we know that 40% of hospital admissions from care homes follow a fall. So this is a significant risk, and there's lots of work going on behind the scenes so that hopefully patients, when they're in care homes, we lessen the risks with them. Now, some of you will have heard of the silver tsunami, which I personally think is quite a derogatory term. But basically what that means is since the mid-50s, our population has been expanding massively. And what we now have is this silver tsunami. And that basically means that by in the 17 years time, we're going to have more than 16 million aged over 65. I'm included in that group as well. But to me, silver implies a standard that's less than gold. And if we think about the Olympics, then actually silver is second to gold. And actually for older people, they're more frail. They've got other things going on. We should be treating them better. And that's why as a network across both Thames Valley and across the whole of Wessex and in the ambulance service, we refer to it as platinum tsunami because it's a standard more valuable than that of gold. This is a slide that shows us all 999 calls. I've got 21 of our 999. You can see I've put them into themes here. And what you'll see on the right-hand side is other medical. So on the left axis, we've got percentage of calls. So up the y-axis there. And along the bottom, this is the common calls for 999 calls. We've got a big group, which is other medical. That'll be, for example, patients that aren't feeling very well. Maybe they've had a faint or collapse, those sorts of things. But what you will see is that our second highest number of 999 calls relates to patients that have fallen. It sits at about 14%, 1-4. So that means that between 1 in 6 999 calls, between 1 in 6 and 1 in 7 that we go to will relate to somebody who's fallen. And if anyone's joined the ambulance service to go to mega accidents like major trauma and cardiac arrests, they're going to be sorely disappointed because thankfully those are actually relatively rare. This is a map this is a graph that shows us really interesting data about trauma within South Central Ambulance Service. So this data comes from our electronic records. Our crews input data into our electronic records, and this basically shows us our themes. And I'd like us to focus on the orange and burgundy colours here. So first of all, you can see that the orange colours along the bottom there, we've mapped ages. So 0 to 4, 5 to 9, 10 to 14. You can see the ages along the x-axis, and then you can see the percentage of patients affected by this mechanism of trauma. So what you can very clearly see is that road traffic collisions, which are marked in orange, are very much a problem of the young. It's very rare you see a 95-year-old doing handbrake turns around the car park in Hedge End Sainsbury's, but you absolutely do see that in 15, 18, 20-year-old kids, and that's because unfortunately they're unaware of the dangers of it. And this is really nicely mirrored in this map. What you'll see marked in burgundy is patients who have fallen less than 2 meters. And what you can very clearly see is we do see some significant falls in the very young, that 0 to 4 group. But as we get older, you can see a massive increase in the number of patients who have fallen less than 2 meters. And falling 2 meters is actually a very dangerous mechanism, and I'll cover that in the next couple of slides. We know that falling over is bad news because a lot of patients will have comorbidities. That means that they're living with other conditions. That might be, for example, osteoporosis. So they may have brittle bones and they're therefore more likely to become injured. We know that many patients are already frail, and obviously falling is never good for that. In the UK, falls are the most common cause of injury-related deaths in people over the age of 65. And we know that 40.1% of all major trauma taken to University Hospital Southampton, the major trauma centre, actually relates to a fall of less than 2 metres. It's not all about being stabbed and being, run over and everything else. Actually, a significant chunk, in fact, the largest chunk of our major trauma, it relates to somebody who's fallen less than 2 metres. Falls are really bad in that they cause a massive loss of confidence. If you've had a fall, you're going to be worried that you fall again. There's a feeling of loss of independence. What typically happens, my mum's now in her 80s and I'd be exactly the same, is if somebody's had a fall, you'll see the family gather round and everybody's very supportive. And actually that means that that older person is actually going to struggle with their own independence. And that a lot of people have, real pride in being able to live independent lives. And suddenly when people gather around and take over, that's a massive issue. Obviously, we know that patients can fall and injure themselves, so things like hip fractures are really common. And we know that patients, when they lie on the floor, become dehydrated. Some people deliberately keep themselves dehydrated. We often see older patients, particularly males, who need to get up for a wee in the middle of the night, will deliberately not have anything to drink after 6 p.m. so that they don't have to get up in the night. So sometimes these patients are already dehydrated before they've actually had a fall. Lying on the floor can be really poor. I've been to patients that have been on the floor for hours, sometimes days, and it's very common for them to have a very low temperature, what we call hypothermia. And we know that lying on the floor is really bad for you. It causes all sorts of issues, conditions that some of you will have heard of, like rhabdomyolysis, which is where, unfortunately, muscle starts to break down. You can get pressure sores, you can get burns if you're lying against a radiator, and it's really, really dangerous. So, in South Central, bear in mind we're a large patch. We go all the way up to Milton Keynes, across to Banbury, and then all the way down to the south coast. I've actually got some hotspot maps to show us where patients fall. This is really interesting. If you see little blobs, that means there's one incident. If you see big blobs, that means that there's many incidents. And the large blobs are 10 incidents or more. So this looks at a year's worth of data, and what you can very clearly see is that we've got some big pockets, particularly down on the south coast here. Portsmouth, as you'll see, is actually quite high, but also we've got areas like Lymington and areas of the New Forest where typically we have older populations. There's also some areas further north as well, so you can see Milton Keynes and Oxford. And then this graph hopefully will show you. So first of all, focus on the bottom one. That's time of the day. So 0 being midnight, 23 being 11 o'clock at night. And what you'll see is that we've mapped when demand happens. In other words, when patients phone 999, what time of day is that? And what you'll see is that we get a surge in patients who have fallen at about between 8 o'clock and 9 o'clock in the morning. And people often ask why that is. Most of the time, that's where carers go in and find people lying on the floor. And that's when we then receive a 999 call. Interestingly, if you look in the top right box, it says the top 4 age bands. So 85 or over, you'll see that that relates to 47.6% of our falls activity. And you can see as you get younger, it actually drops. So that absolutely backs up the national data about being twice as likely to fall, or 50% of patients who are aged over 80 tumble. And on the top left here, we've got this is called a tree map, but basically what it does is it maps our high demand areas where, for example, we might want to put a falls service. And you'll see that Portsmouth is actually our highest risk, very closely followed by New Forest, and then Southampton haven't. And then as you can see, it gets slightly lesser risk. But I think this is really interesting data. If we get a 999 call, basically what we do is we put them into one of 4 categories. I've very deliberately put a trump card here of a Toyota Prius. I'm not a salesman for Toyotas, but anyone who's played trump cards will know that a trump card will be everything. And the Toyota Prius wins on everything: reliability, distance, servicing costs, customer satisfaction, everything else. And what that basically means is the trump card that wins everything in the ambulance service is our category 1 call, our most serious emergencies. And I'll talk about what sits in those categories. So category 1 is actually a very rare category, but it's patients who are have an immediately life-threatening condition: cardiac arrest, choking, fitting, unconscious, drowning, those sorts of conditions. But as you will see, falls are not in that category. Category 2 are emergency calls, and they're very sick patients, but they're not immediately life-threatening. Sepsis, chest pain where it's believed to be a heart attack, for example, severe burns, major trauma. That is an 18-minute response. So wherever possible, we will get to those patients within 18 minutes. And it's only when we hit category 3, which is up to a 2-hour response, that we start to see falls. And obviously what happens is if you get a run of cardiac arrest or a run of chest pains, unfortunately what that can mean is that patients who have fallen get a delay to their response, but we will always aim to get to them within 120 minutes. And you can see the other categories that sit in there. And then we finally got our category 4. So if someone's had a fall but they're not injured, they tend to sit in this group, which is 180 minutes. So when our crews get to a patient who's fallen, our crews will perform a thorough assessment of each patient. It's not just about picking a patient up off the floor and saying, "You're fine, thanks very much, off we go." There's multiple reasons why someone might have fallen. They could have had a stroke. They could, for example, have a urinary infection or an underlying infection going on. So for that reason, it's really important that our crews do a very thorough assessment to check that our patient is well enough. So this is a piece of work that I did a few years ago, but what we've done particularly for our students is to map what observations should be done for certain conditions. And this is the top 20 odd conditions that we go to as an ambulance service. You'll see falls sits in the middle here. And when you see a white box, that means ideally we should do that test. If you see a black box, that means you don't necessarily have to do it. And where you see yellow, we should consider it. So when we've got a patient who's falling, we'll be doing pulses, we'll be doing respiratory rates, we'll be doing blood pressures, we'll be doing all sorts of tests, which might include a urine test, because one of the reasons why people fall is because they got a urinary infection. We'll be doing 12-lead ECGs, so this is where we do a full MOT and a really thorough assessment of these patients to help us decide whether they need to be transported to hospital or not. And what we find as a 999 service is 50% of patients who have fallen are not taken to hospital. Many patients don't want to go to hospital, but we have to assess whether that's safe or not. So what our crews will do is what's known as a RAG rating, and Hannah and Harry will be talking about RAG rating, but that basically means categorizing patients into risk. Are they red? In other words, are they high risk? Are they amber? They may fall again. Or green? It was just a one-off, they tripped over the cat. They'll also, our ambulance crews will refer patients to their GP. We have brilliant access in some areas to falls services. So that's where, for example, you've got really highly qualified occupational therapists, physios, paramedics, all sorts of staff out there who are able to take over patients in the community. And that's a massive plus for us. The other thing we do have is a cadre of staff that we've trained up, not with a focus on going to all the life-threatening emergencies, but much more to admission avoidance, trying to keep patients out of hospital. So in SCAS, we've got 80 specialist practitioners. They're trained to deal with a huge range of patients with chronic illness and injury as well. And they can do things like wound management. So they can stitch, they can staple, they can glue, they can do all those sorts of things that actually prevents a patient from needing to be taken to hospital. And they can deal with lots of other conditions as well. But unfortunately, 50% of patients will be transported to hospital, and that's often because they've got an injury. So they may, for example, have fractured their hip. They may have an underlying illness, a chest infection, a urinary infection, those sorts of things. And what that means is it's not safe for them to be managed in the community. They may need to go and, for example, have intravenous antibiotics. In some cases, they may need surgery. And in some cases, it's too dangerous to leave a patient at home. So if you've got someone that's fallen over a couple of times in rapid succession, clearly it's quite likely that they're going to have another fall. And if our crews are really concerned and feel that it's inevitable that person's going to have another fall, then clearly those patients are going to be transported to hospital. So I'm going to hand over to the hospital team because they're going to explain what they do. And thank you very much for listening. We'll take questions at the end.
Thank you very much, Matt. Thank you. So over to Harry and Hannah. And as Maz mentioned, please do pop your questions in the chat if you'd like, or there'll be an opportunity to ask questions at the end too. Thank you.
Evening, everyone. So I did introductions earlier, but I'm Hannah, so I'm one of the occupational therapists at Southampton Hospital, and I've got Harry joining the talk with me, who's one of the occupational therapists who works in our Medicine for Older People team. So we're here today to talk about strength-based approach to falls and frailty management in the acute hospital setting. So it follows on from what Maz has just talked about. So those patients, when they come into hospital, we'll talk about their journey. So we'll be talking about the patient journey in Southampton hospitals for those patients that present with falls and frailty, the standard therapy interventions that we'll do, the work that we do to get people back on their feet after a fall. We'll also be talking about some of our exciting innovation projects as well that have supported people who are admitted with a fall and supported kind of that rehab journey as well. We'll be talking about falls prevention and management in hospitals and post-discharge. So just to start off, I'm just linking it to a lot of the work that we do. You might have heard of the NICE guidelines. So it's the National Institute for Health and Care Excellence. There's a lot of guidelines that they provide, but they've got ones that are around falls, and they've recently updated their falls guidelines in April 2025. So a lot of the interventions that we provide, we link into the NICE guidelines in terms of the assessments that we provide for our patients. So we're identifying people who are at risk of falls. We complete a comprehensive falls assessment. So we're very kind of patient-centered and holistic in how we manage our falls assessments. Interventions to reduce risk of further falls. I'll talk about that a little bit later on. And maximising ongoing participation in falls prevention. And we also look at information and education to prevent future falls. So this is just a graph. So we know that our emergency departments are very busy, and we've seen over the past couple of years that has been really quite consistent in how busy we've been. The red line there is where it did dip was in 2020 during the pandemic, but since then it's been very consistent in terms of how busy our A&Es have been. So we do have a team that works at the front door, a therapy service that, and I would say a vast majority of their caseloads are patients that are admitted with falls. They're a mixture of both occupational therapists and physiotherapists that work in this team, and we also have therapy assistants that work in the team as well. On average, they see about 567 patients in the emergency department, our assessment units, and our same-day emergency care, and averagely they discharge about 51% at the front door or within that emergency department. So they try and turn patients around. So if they have come into hospital and they've been treated for what they've been brought in medically, the therapy team will do what they can to get the right support in place and do an assessment to make sure that people are going to manage at home if we do send people back home. So the falls interventions that we provide, so we use what we call the FRAT, but it's referred to the Falls Risk Assessment Tool, and this is a really good tool because it looks at things quite holistically. So we look at like mobility, but we'll also look at like the environment. We'll also look at other kind of risks as well around future falling and things like cognition as well. So we use the 418, which is a delirium screening tool, because we know sometimes that if someone does have delirium, that can increase their risk of falls. And we do use the Oxford Strength Scale as well to look at where weakness might be, because we know that weakness can sometimes contribute to falls, and we do a lot around falls education and gait re-education as well. And within that emergency department, we have access to equipment. So actually, if we get someone up on their feet and we feel that they're not safe, we have got access to things like walking frames and other pieces of equipment that can support people to kind of reduce that further risk of falls. We very much focus on integrated working. So if we are sending people home, we can refer directly into care to get care out in the community, and we can also arrange the community therapy follow-ups as well, and we can refer on to the sensory sensory teams as well if we want them to go out and check that kind of home environment to see if there's things that we can put in place to support people at home and prevent that further risk of falls. And for those admitted, we do what we call early therapy intervention. So we know that there's a chance that if you are left in bed or left on a trolley, that you're going to kind of lose that there's that risk of muscle breakdown, and actually it's so important to get people moving as soon as possible. And we did mention earlier about how people lose their confidence, so we know it's important to get people on their feet as soon as possible. So our therapists will work to try and get you back up and mobilizing in a safe manner as well within the emergency departments, and if you are being downstream, so sent to one of our elderly care wards or to a different ward, that they will kind of identify those who are at high risk of fall, so that can kind of be managed as well, and we will use that kind of category rating in terms of on the wards to manage falls as well. And just hand over to Harry now for the next slide.
Thank you, Hannah. Evening, everyone. So yes, I'm one of the occupational therapists that was working on the medicine for older people's wards at the moment. And when someone does get admitted into the accident emergency and they do get what we call downstream, they come onto one of the wards that they will stay for a little bit longer than normal to help see whether we can reduce their risk of kind of readmitting as such whilst they're in hospital. So from my point of view, I am in a team which looks after 7 different wards in the University Hospital Southampton. That equates to approximately 200 beds. And within those wards, we see a plethora of patients ranging from people who've admitted with falls to people who may be dehydrated, people who may have mixed up their medication and therefore has become delirious and needs to be admitted because of that. I would say that quite a huge portion of our patients have histories of falls or are what we call frequent fallers because they have had a extended history of falls whilst they're in the community. And I will also say that just because someone has been admitted into hospital, it doesn't mean that they stop falling, unfortunately. We do unfortunately get cases where people get admitted into hospital and they still have falls, regardless of whether it's a mobility issue, medical issues, medication issues. Okay, so our therapy team also consists of occupational therapists, physiotherapists, and also therapy technicians who will screen these patients and see whether there is anything that therapy can do to support these patients while they're staying in hospital. Okay, once we've identified these patients who have maybe come in with a fall or at risk of falls or is scoring quite highly on the frailty scale, we do pick them up to see what kind of bespoke therapy interventions we can provide to these people. Our interventions are quite similar to what the therapy team will do down in AMU. However, because they are staying a bit longer than the period that they would spend in AMU, we do have a bit more time to play with and to kind of implement more sessions with these patients to make sure that whilst they're in hospital, they don't lose that ability because they're in hospital and they're not doing what they used to do when they're in the community. So we also kind of look at further outcome measures such as the elderly mobility scale, which looks at both the mobility and the functional side of things. There is a huge study to show that people who score higher on the elderly mobility scale and also maintain a high score is able to kind of manage better once they're in the community. And we provide those bespoke therapy exercise programs to make sure that they are able to maintain a high score during their period of admission. We are also looking at things or projects that have been running for quite a few years now. So people might be aware of the End PJ Paralysis project that started more than 10 years ago, I believe. And it's talks about how when patients get admitted, if they are kind of left in their pajamas, they tend to kind of fall into the role of, oh, I want to stay in bed because I'm in my pajamas, which, you know, a lot of us do on a weekend, if we don't want to change out into our casual clothes, so we just stay in pajamas, and we might just decide to stay in bed. Now, that has more of a detrimental effect when you're in hospital, because you're already doing less in hospital, and for you to then kind of fall into that feeling of wanting to stay in bed will decrease your mobility, and in the long run it will have more effects from a muscle wastage point of view. And that's when we start seeing people have more falls, both within the hospital setting and in the community. Our response to end PJ paralysis was Eat, Drink, Move, which is a project we started, again, more than 10 years ago, to encourage people who are in hospital to eat more, drink more, and therefore move more. It's one of those things where if you don't have one, you can't really support with the others. If you don't eat, you're not going to have enough energy to move. If you don't drink, you're going to become dehydrated. You might not want to move as much. And therefore, we do try and encourage, as an MDT as well, with the nurses, the doctors, and also the therapy team, to have patients eat more, drink more, and therefore allowing them to possibly be able to move more. And finally, once from a medical point of view, these patients have all their medical things sorted, we'll look at kind of discharging this patient both from either the therapy caseload, but also from the University Hospital Southampton. And to do that, we look at the holistic side of things, what that patient has come from a home environment point of view, whether we can put in more support from a social point of view. Are there any referrals that we can do to social services, to community therapy team, to carers, just to give that patient a little bit of support when they come out of hospital, for them to be able to get back into or get back to their baseline, or as close to as possible. And in terms of kind of any innovation work as well to help support the patients who are frequently falling or are at high risk of falls, or patients who do score high on the Frailty scale, we have come up with a few projects that we have been running. So in terms of proportionate care, this is formerly known as the single-handed care team. We are looking at kind of working with patients to enable these patients so that they are getting involved in their own care. They're not having care provided to, but we are empowering them so that they can take charge of their own care and have that independence. And we look at making sure that when we discharge patients and when we're working with them on the ward, that we're not doing too much, or we're not misprescribing care in a way that it's going to cause these patients to do less for themselves and therefore get weaker whilst they're in hospital, but also in the community as well. And Hannah is in charge of that project, but if she's got any more to add as well, she feel free to pop in. I think we're going to talk about that later as well. We also have the exercise practitioner project on the Medicine for Older People's ward, and this was a project that was started to allow those extra sessions for those patients who might be at a higher risk of deconditioning or getting weaker whilst they're in hospital, providing them with that extra bit of therapy to make sure that they stay strong while they're waiting for the medical side to be sorted, or while they're waiting for care, so that when they go home, they don't find themselves in a pickle and get readmitted sooner rather than later.
Okay, so just talking a little bit more about the proportionate care project that Harry mentioned. So proportionate care, so I've included an NHS England reference here. So it's a person-centred assessment of individuals moving their hands and their knees, ensuring the person receives the right amount of care, treatment in the correct environment whilst creating capacity across the system. So a lot around this project is promoting that independence. I think often people come into hospital, and particularly if they've lost their confidence from having a fall, that we can then often provide the care, and we do too, rather than do with the patients. So a lot of this is focusing on empowering the patients whilst they're in hospital. So actually, if they normally manage getting washed and dressed, doing as much as they can, even if they have got an injury, but to kind of work together around that kind of rehab journey. And we have found that this has the feedback we've had is that it increases a person's dignity and promotes that independence. And it also, by doing that, it might be that you don't need as much care going home, and that can kind of reduce your length of stay, because sometimes we do have quite a long wait awaiting onward care post-hospital discharge as well. So it's really about getting people back home in a timely manner and obviously promoting that independence as much as possible. Okay. And by doing this and promoting a strength-based approach, we found that actually that can reduce the risk of inpatient falls and reduce the risk of pressure sores, because we're keeping people active, we're getting people to be involved in their moving and handling and their care needs, and it's kind of reducing that risk of inpatient falls and pressure sores as well.
And again, a little bit more about the Saints Foundation Exercise Practitioner projects from University Hospital Southampton. We are trying to tackle that deconditioning within the elderly population. By deconditioning, I mean people just getting weaker from a general sense because they've been in hospital. That might be because that they're less active while they're in hospital, or whether it's because they've had an episode of illness which have knocked them down a little bit whilst they're in hospital. Okay, and in terms of this project, we've had to think about what are the different ways of engaging this certain group of people into doing more exercise, basically in a fun and active way, because we all know exercise can be a chore at times, but being creative and engaging these people in a way that doesn't look like we're just therapists going in to provide therapy. And that's why we rolled up this new role within our team. And again, it's thinking about how we can maybe kind of look at, is there a specific time that we should be seeing these patients so that they are more likely to engage with us? Is it because that this person that's come in after having a fall doesn't normally wake up until 11 or 12 in the afternoon? And in that case, do we need to be creative with the way that we're providing these exercises? Do we need to bring them into a group environment where they're seeing other people engage in these exercises, so therefore that's going to encourage them to engage in exercise as well? Or do they do better in a one-to-one environment where we are sending people to do very bespoke strengthening and conditioning exercise with them whilst they're on the ward? I think it's just to it highlights the fact that we are promoting this functional approach, this approach that it's not a therapist coming in to do therapy with you. It's someone who has had a look at everything and make sure that actually the way that we are working with these people are suited to them, and it's not just a blanket, oh, here's some therapy for you, here's some therapy for you, and promoting that rehab ethos whilst they're in hospital. Okay. Just a bit of stats about how much we've managed to engage our patients. So in September 2024 to the end of May, we've managed to engage about 399 patients with a mix of group exercise classes to one-to-one sessions. Okay, and we know that by implementing these extra sessions, we've managed to support these patients into getting back home on their predicted pathways. Now, with regards to that, some people unfortunately do end up going home with possibly more carers than they need, or going to a short-term placement such as an inpatient rehab setting before they go home. By implementing these sessions of exercise class or one-to-one, we've been able to promote the idea that actually these patients wants to go home. We're trying to get them stronger or maintain their strength so that whilst they're in hospital, they don't then decondition and therefore they're needing more support. And yeah, as the stat shows, we've managed to maintain about 360 patients on their desired pathway that was predicted from their admission. So in regards to the next steps, what we're trying to kind of promote within our hospital as well, but also hopefully to the wider community, we're going to look at starting a deconditioning pilot within a couple of our wards, which will almost promote this idea that actually we don't want these patients to decondition. We want them to be able to at least maintain the level of strength that they've come in with, and integrate all of the data that we collect on these pilot wards into almost like a business as usual model, where the techniques that we're using, techniques that we're upskilling staff with, will be a standard practice almost. We're also working with the Integrated Care Board and NHS England to disseminate some learning material, and we're in the process of kind of filming and processing and putting together videos that people can, or carers can have access to maintain this kind of preventing deconditioning ethos when they're caring for patients in the community. And finally, we're developing some e-learning resource to upskill staff both within hospital settings and within the community. We're still working around the logistics of that, but we're going to try and make this e-learning resource as accessible as possible. Yeah.
Thank you very much. Thank you. That's brilliant. So, so there's two excellent talks, and thank you for putting the information into the chat for questions. And now I'll hand over to my colleague Tim to take the questions forward. Thank you.
Thank you, Helen. Yeah, and I've been watching all the activity in the chat go by, which has been very interesting. Thank you for respecting the speakers so they can get through the material they'd like to share. I have summarised a few of the questions, so just bear with me. Hopefully you'll recognise your question. The first one is to Maz, and it's a question from Karen. She says she has a family member who has landed in hospital on 4 separate occasions, despite the family's best effort to prevent it. And she feels there doesn't appear to be joined up care between SCAS and general practice that could help with admission avoidance. Is that a fair perception on your part? And what can the family do to help bridge the care between the emergency services and the long-term care? And I just know that Jeanette mentioned urgent community response as one way in which that happens already.
Yeah, so first of all, we've currently been rated as the second highest ambulance service in terms of non-conveyance, in terms of transporting patients to hospital, and that is a tribute to our general practitioner colleagues who we work very, very closely with in the community, and that's where we'll take on shared care. In terms of communication, our crews, I've already mentioned about electronic patient records, EPR. What that means is when the crew type up the notes, that's then visible to the GP. So there should be good continuity between what the ambulance crew have written and then what the GP actually sees, which is obviously really important. We know that a study myself that I did with one of my colleagues, we showed that at every handover you lose 25% of information, and so it only takes 4 handovers and you end up with gobbledygook. So this is why it's so important for this written format to be transferred across to our general practitioners. So we do work in partnership. We've got some amazing, and it is regional, but we've got some amazing falls care services out there in the community. They offer an amazing package. We did do a study some time ago, and what we found was if we had reactive community services who could respond, for example, within 2 hours, the chance of that patient being taken to hospital was hugely reduced, because if you were leaving someone at home, you knew that they were going to get an expert coming round. So I think, I think there is joined up care, but I absolutely take on board that sometimes it doesn't feel like that.
Thank you. And for Hannah, we had a question from Councillor Drew, who's interested in helping to promote fall prevention. So asks, what's the best way to reduce the likelihood of a person falling? And are there literature, leaflets, things that can be shared with community groups and parish councils to provide suggestions to minimise falls? And in the chat, Emma did mention the Get Up and Go leaflets, but I don't know if you have any other things which you're aware of.
Yeah, I was literally just about to say about the Get Up and Go leaflets. Also, Age UK, they do a lot around, as they also do education around like falls prevention stuff as well, and they have got groups. In terms of things to help, there's sometimes even like things like the environment. If we know that if someone is at falls risk, we often recommend like rugs and things can be taken up for things that like trip hazards. So considering things like the environment as well is really, really important. And often we can get a community therapy referral in to kind of go and look at that home environment, and even look from like a sensory perspective if there's things that we can kind of put in place to support, as well as doing kind of what I mentioned earlier about the re-education around like gait education and actually preventing falls from that, and doing balance work and things as well. So I think it's like I said earlier, I think it's very much about having that holistic approach, and looking at kind of every angle to it.
Lovely, thank you, Hannah. I've got one for Harry, which was a question that Claire raised here, because she described a situation where her 80-year-old sister had a fall, and luckily she was okay. The adaptions team have been alerted to check on her requirements in the home, but as a carer, she has additional communication needs. So what systems are there in place to help ensure communication is more streamlined and efficient for carers and people that have that additional need?
So I can speak on behalf of the UHS. So we normally have quite a clear handover in the discharge summary with regards to kind of care needs and things like that. So it might be worth getting into contact with the local hospital that was it your family member or sister has been admitted, and see whether you can get a copy of that so that the carers will have a copy of the discharge summary. But in terms of communication within kind of the community teams, so I think it's really important that you have recognized the concerns, but also highlighting it to the carers so that they are aware that it may be that the communication has been not as good within the community, because I think that is a really good identification of that, and sometimes that is not realized, unfortunately, within the teams themselves.
Yeah, thank you. Hannah, can you say whether the services that you and Harry have described here and the pathways that are followed, are they the same across a broad area, or are you talking specifically about the University Hospital of Southampton?
A lot of hospitals have a front door therapy service in terms of that emergency department therapy service that does look. So if the ambulance crews have had to bring someone in and they've been treated in the emergency department and can be sent back home that day, a lot of hospitals, or as far as I'm aware, all our local hospitals have that kind of therapy provision in the acute medical units and in the emergency department. The innovation work that we spoke about, that they're kind of quite unique to Southampton, I'd say. The proportionate care work, where I said about obviously engaging people in their care and things, is something that I'm working with the Integrated Care Board at the minute to roll that out more at a regional level. So that's definitely something that's been looked at in other areas moving forwards.
Lovely, thank you. We had a question which I thought, Maz, you'd be able to help with. This is from a combination of questions from Adhikari and Councillor Drew. What would you say are the top 3 morbidities that you typically see as a cause of falls, and the things that can be done to reduce the falls for those people who are more vulnerable?
So I suppose what you can do really is divide. It's not just about comorbidities, it's about the environment as well. I think that's really important. When it snows, don't go out. It's a simple thing like that, and we do see it when there's winter months. People have to go out and get the newspaper, and that always ends in tears. So there's environmental factors. Don't forget that a lot of people, you've got really supportive neighbours, for example, who will go out and get your newspaper or your pint of milk or whatever. We've got other comorbidities such as osteoporosis. So obviously, as we age, our bones tend to thin, and what that means, it means that we become more fragile, and that means that if we fall over, we might break our wrist, when if we were younger, then we may just sprain it, or not even that. So, and that's quite incapacitating in itself. If you think about having your arm in a plaster and it's your dominant hand, then actually for somebody that really relies on their hands, that's a definite issue. And then we see sort of medical conditions as well, and some of those are related to things like alcohol, and they can be also related to medication as well. So what we always suggest is that if somebody's suddenly having falls, we always have a tweak we've got the experts on the call here, but it's sort of a medicine review. But there are a serious cohort of patients out there who do drink too much alcohol, and it's quite common to go to a patient's house and find that there's sherry stashed behind the sofa. There are all these things that we can do to try and prevent ourselves from being injured.
Lovely, thank you. Yes, Andrew has just posted in the chat that about medication and ensuring that doctors and pharmacists do regular reviews of people who are on multiple types of medication who may be at a high risk of falls.
Yeah, that's really important. So some, for example, sleeping tablets are absolutely renowned for it. So obviously you lose your coordination, but there are things that can reduce your blood pressure, which of course are really important. But what that means is that you can suddenly drop your blood pressure, and that's why we recommend a medication review, and pharmacists offer us a huge amount of expertise.
Thank you. Back to you, Harry, if I can. A comment from Karen about the need for good diet as well, and whether that is being promoted to carers, specifically mentioning dehydration, diabetes, other things which are going to contribute to people falling.
Yes. So typically what normally happens is that all of the concerns that we would identify in the hospital would get put into a care plan for the carers to follow up with, or regardless of which team is involved. So normally we would need to involve a couple of teams. For example, if someone has diabetes, they might need to have the community diabetics team to go out and review that patient. But yes, any concerns that we may have highlighted or identified in the hospital should normally go on this care plan that the community teams should get a handover of. However, that's not to say that we will always identify all of these concerns, and it's also important, again, from a family point of view. If you guys have any concerns about family members that have been admitted, to highlight these concerns onto the wards so that we can look into these properly and have a clearer handover once this patient is discharged.
Hannah, Carol's mentioned that about the importance of podiatry care. Is that a common cause of falls that you're seeing in practice? People who are not perhaps taking good care of their feet?
Yeah, it can be, and along with that, around footwear as well is also a big one, and it's part of, like I said earlier, when that falls risk assessment that we do, when a patient comes into hospital as well. That's part of one of the things that we look at, along with things like the medication and the environment and everything else. And we have the ability to do onward referrals if we think that there is a need there, and that might help in terms of further falls risk prevention.
Lovely, thank you. Maz, what's the most helpful thing people can do while they're waiting for help after a fall?
I love that question.
Either the person that's fallen themselves or somebody who's with them.
I love that question, because actually sometimes we arrive and patients are uninjured, but people are often very scared about moving somebody that's had a fall. And I absolutely get that. What we don't want to do is to aggravate an injury. So if someone's fallen and cracked their head, then of course we need to think about, for example, a neck injury. But if somebody is lying on the floor and they're saying, I'm fine, then actually, if we've check them out and we're really reassured by that, then getting them off the floor is one of the most important things that we can do. Obviously, if someone's got for example, a hip fracture, they're not going to let you do that, and certainly we wouldn't advocate moving anyone with a serious injury. But actually getting people off the floor, keeping them mobile is really important. And the way we reflect that is we divide our falls patients into two groups. We've got our immobile long lies, so that's people that lie on the floor and cannot move, and we've got our mobile long lies, and our mobile long lies are much less likely to be transported to hospital. So if somebody is very seriously injured, or they've got a hip fracture or something really serious, then please do not move them. One of the things we have in our control room, which is incredible, is called live links. I don't know if anyone's heard of this. So our clinicians working in the control room can actually say, can we take control of your mobile telephone camera? And they can actually use that. So for example, if they do see serious injuries, maybe a hip fracture, our staff can actually upgrade those calls and make them more urgent. So having a phone there that's got a camera is actually really important. And live links is being used increasingly by our clinicians in the control room. So The other question quite often people say is, can they eat and drink? Well, if someone's likely to need an operation, then usually we advise against giving drinks, but actually we know that lying on the floor makes you dehydrated. So if somebody's relatively okay, giving them something to drink, a cup of tea, a glass of water, actually can be really good. It will just prevent them from getting those complications that we discussed earlier.
Lovely, thank you. Hannah, we've spoken a lot about falls with the elderly. Do you have examples or cases or trends of non-elderly patients falling and what that might entail?
Yes, so our teams that are involved in terms of our therapy teams, that they see people of all ages. So it's normally from 18 plus, because it's from our therapy teams are commissioned at the front door from the emergency department from 18 plus. But yes, so we do get a mix of ages, and that can be lots of different factors, like we said earlier, whether sometimes it can be related to lifestyle choices. Like we said, obviously alcohol can be a big factor, but there's also things like if someone does have neurological conditions like MS and things like that, that also can play a factor and be a high falls risk. And again, it's around that managing that risk. So and like we said, earlier, like we said, if someone hasn't got a fall, we do like backward chaining, which is a way of like supporting people. So our community teams work a lot with that, helping people get back on their feet if they've had a fall and they're uninjured. So they've got techniques from a therapy perspective that can support with that as well. But yeah.
Lovely, thank you. And Harry, to bring it back to a more positive step, I'm interested in things that people can do on a practical level to avoid becoming a faller. So I'm thinking of preventative exercise to keep bones strong, those sorts of things, but also equipment to help people feel safer at home or when they're out and about using public transport or in public.
Yeah, so in terms of exercise, it will need to be on a case-by-case basis. I wouldn't be able to tell people exactly what to do in the chat, because unfortunately, where there are no textbook fallers, there are no textbook exercises, there is not always a solution to or one single solution to solve all the falls in the world. However, I think it's really important that if we are able to keep mobile, we do keep mobile, and not to fall into the trap of kind of, again, I'll bring it back to the word deconditioning whilst you're on your own, or getting weaker in general, because we all have those days where we feel ill, but that can fall into we can fall into a habit of feeling that every day. And if it is the case that you are feeling generally weaker, it might be worth contacting your local GP to see whether they can do a review to see if there is anything medically going on. There are also services available from a social service point of view. Social services will have therapy services such as OTs that can come out and have a look from an equipment point of view to see whether there is anything that equipment-wise we can put in place to promote independence and maintain people's independence when they're in the community in their own home. Obviously, that is all down to the assessment of the therapist and whether people are eligible for that. But I think it's important to realise that unfortunately we all grow old, and we all do unfortunately get more and more frail as we get old. So being able to recognize that and being able to accept that actually sometimes you do need a bit more support than normal, or you're getting to the point where actually someone coming in to help out once in a while isn't too bad, is the first step of kind of being able to accept change whilst maintaining your independence in the community.
Thank you, Harry. So we're coming to the end of the hour, and thank you very much for all the great questions that are going into the chat. There will be a follow-up to this meeting where links will be sent out to a recording of today's session and an opportunity to send some evaluation feedback to the speakers, which I'm sure they will appreciate hearing that from you. I tried to keep up with the questions, and we're just kind of getting warmed up there in the chat. If there are any questions which we haven't been able to address today, likewise, we'll be able to follow up after the meeting. So thank you for joining. Big thank you to our speakers for sharing their very helpful and practical advice. As you've heard, there's a lot of things that are happening in the area of falls and frailty, and lots of things that we can do as well to stay independent longer. So thank you very much for joining us today, and we'll look out to see you on the next public talk.
Thank you very much, all very interesting.
Thank you.
Thank you, everyone.